Good afternoon to the ones that are connected. My name is Nidiana Nunez, and I'm going to be your moderator this afternoon. I welcome you to our webinar series for multidisciplinary chronic conditions in primary care. We welcome you as you join us today, this afternoon. This project is sponsored by HRSA with the project of learning through telementoring, TTELP, and the purpose is to connect specialists from academic medical centers with providers for primary care in rural areas. If you share this link, be sure to put your name correctly so that you can have your certificate. Well, please turn on your camera. We want to know you. You want to write, you are able to write in the chat at any time during the session. Please open your microphone to ask questions. And this webinar is being recorded for educational purposes. And yes, we are sharing them in our digital area. And you're going to see the information on this digital area in the chat. This afternoon, we have Natashalee Rivas. So I'm going to leave her so that she can introduce herself and share the presentation with you. Thank you so much, Nidiana. I am going to share my screen. Diana, we have a technical problem, and I have some issues here. If you could help me. Let's wait a couple of minutes until they can help us with that. Here we go. Perfect. Very well. Perfect. Please let me know if you can see the screen. Yes, we can see it, but there is an announcement, some kind of notice on the screen. There we go. Now we are doing fine. We are still having some technical difficulties. We're still seeing the notice on the screen over the presentation, so we're going to see what we can do to fix that. Okay. Now we're seeing the presentation. I'm so sorry for the inconveniences. Well, good afternoon. My name is Natashalee Rivas. During this afternoon, I am going to be your presenter on the billing and reimbursement process for telemedicine. This workshop wants to educate you on the medical billing processes for telemedicine services. As part of our educational division, Opera was working on the Opera Workforce Development and Healthcare Operations Partner for Puerto Rico, and we're looking to strengthen the capability of the health system through continuous education, development of talent, optimization of administrative and regulatory processes, and orienting people about the compliance and best practices so that they can understand financial education, because everything that is operational affects everything that has to do with money in a medical practice. Before starting with the explanations and definitions of what is a CPT, coding, and financial topics, I would like to see if we can check out this map. And it's a little bit complicated to specify each one of the participations of medical personnel in Puerto Rico. But what I would like to emphasize before we start is that this map means a lot of what we're doing in dividing Puerto Rico in segments, which shows the limited access that many patients in the island have. And aside from that is the way in which people are affected from origination of services, transportation, the people that are helping them, because we have a population that is aging. And through this type of service, we're going to be redirecting through telemedicine to mitigate or at least lessen the problems and strengthen the help and assistance to people that have limited access to services. As you can see a lot of doctors. We have a lot of people that have gone out of the island, medical personnel, and we have situations that are affecting the population in general. The most privileged area with a lot of medical personnel is in metro area, where we can see that they have 42% of doctors in the island are concentrated in this area, Metro and Fajarda. So that allows us to have a lot of data for that. And what I want to reflect on this is that this type of education strengthens the social commitment of you as doctors or administrators, where you can provide information to the doctors on how they can help our country to benefit better and work with the burnout in doctors. Sometimes in the metro area, we have a lot of doctors with a lot of patients, and humanly, it's impossible or difficult to deal with that situation. And it affects the attention to patient because you have to go faster, and the quantity and complexity of the cases we see today. Let's go ahead. Having said that, our objectives this afternoon is to understand regulations of telemedicine of CMS and the current changes, identify exactly the codes to use and which one has been eliminated, correctly document so that we can be better with audits and Medicare and Medicaid, and know your rights as a patient in the era of telemedicine. To start, we have the definition, the original definition for CMS. Telemedicine consists of services that the provider offers using technology of interactive telecommunications, audio and video, bidirectional in real time, in such a way that it substitutes the in-person visit. It's important to say that telemedicine is a method of delivery. It's not a CPT of services in itself, but it's the way in which we explain how the service was offered, how we worked with the patient to be able to serve them. For Puerto Rico, telemedicine and Medicare and Medicaid legislation and the regulations under the jurisdiction of 2026, it was 2025, but right now we have a lot of denials because they're using codes that are no longer here. So we're going to focus on that. For Puerto Rico, I'm sorry, for Puerto Rico, we are ruled by ACES, and it is under legislation that telemedicine has to be reimbursed with parity of in-person services. So if you provided telemedicine services, that doesn't mean that you're going to get the cost or the price of a CBT of evaluation and management. In this guide, we have the providers that are eligible to offer this type of services. And we're going to focus later on the doctors and the type of services that can be used in telemedicine. But right now we're going to start with the doctors that can be providers for this type of medicine. First of all, we have a doctor that is a general doctor. These are all the specialties that are covered: nurse practitioners, clinical social workers, psychologists, nutritionists, dietitians, uh, speech therapists. And aside from that, I want to emphasize on the fact that telemedicine deals with service and the connection that you're going to have with these patients. Act number 8 of 2025 eliminated the additional certification for telemedicine. What does that mean? During pandemic, COVID-19, we had legislation to allow for a certification that had an expiration date. And if you didn't have that certification, you couldn't provide that type of services. And if you did provide it, you were not going to get paid unless there were adjustments or appeals and that type of thing. However, from 2025 on, we saw that telemedicine is here to stay. We could see that there was a growth, at least in the United States, in terms of the ease of service for chronic diseases. An important data here in Puerto Rico, we have some 37% of doctors that are working right now on the island offer telemedicine services, and the data shows that 2.7% is willing to implement it. Many times it's because they don't know, because they're afraid, or sometimes because there's a lot of bureaucracy in terms of the insurance, medical insurance. So we're here to show you what the tools are so that you can see how you're going to offer the service and how you can be remunerated for that. Right here, we see that on December 31st, 2027, the Consolidated Appropriation Act that was signed in February 3rd, 2026, extended the flexibility for you to provide telehealth to Medicare until 2027. So we are on the year of 2026, and we're not going to see anything as an update in 2027. And that means until 31st December 2026, you're going to be able to continue offering telemedicine services and are going to be remunerated with no problems at all. However, the coverage principles are very important because basically they tell us what we can and cannot do. Right now, Medicare has a list of services for telemedicine and coverage. So you can find it in the telehealth uh, services and the government. You're going to have the link and in your handout. I don't know if I should share it or you're going to share it, Nidiana, so that they can have it during the presentation. We can share it, of course. So you're going to have there all of the details so that you can have it all of the time aside from this presentation, and you can go over it, and all of the rules that are established are going to run until December 31st, 2026. And I want to repeat this and repeat this because I want you to understand that these services are very helpful and will be remunerated. And what are under the principles of coverage? All of the visits for evaluation and management, including behavior and science, nutrition, and therapy. And it's important to talk that all of these visits for evaluation and management can be codified the same way as an in-person visit. And that's what I said at the beginning. It's a parity of services. Telehealth is a delivery method, and the underlying service should be in the coverage list. That means that we're going to code under a hierarchy, and we're going to see it in Billing 101, where we're going to explain how to code specifically for each area. And it's important to emphasize that Medicare Advantage plans can cover additional services aside from what original Medicare does. So it's a different rule for Medicare Advantage, and it's important that you talk to the payers. This type of connection is very important because you can understand what the infrastructure is for delivering the service. But when we're going to bill, we need to go back to the contract and the rules of the payer. So whatever you are accepting in your medical practice, you have to go to that insurance plan and check it out. We can see here that there are some eliminated codes, and we can see CPT 99441, 99443. This was only for audio only calls, and it was used to talk about the method of service, but this was invalidated. So in terms of billing for these codes, it's important that you know that for your financial health, you eliminate these codes. The CPT 98000 and 98015 are invalid. Medicare does not recognize them. 16 of the 7 new codes for telemedicine do not exist. So we have only one, which is CPT 98016, which is a new code. And it tells the insurance plan that there was a brief encounter, 10, 15, 5 to 10 minutes long. So aside from that, we have G 2012, which was eliminated for redundancy and was replaced for CPT 98016. Basically, what we want to illustrate with this table is that the only code in CPT that you can use for coding services is going to be CPT 98016. This is a code that is going to affect your finance. And the other codes that we mentioned before should not be used so that we can improve operations and financial health in your practice. And it's critical here that we don't use the eliminated codes because this will mean that your billing will be denied. So you have to update your billing services and code system. And in terms of the coding area, MPFS applies only to the original Medicare, which are parts A and B. Basically, when I'm explaining the MPFS area, it tells us the menu. Remember, think that you're going to a restaurant and they give you a menu of what you can eat. In this case, in the Medicare area, in MPFS, they tell us what services we can perform and how you can provide them and how they can be billed. As we discussed in the previous slide, these rules apply to the original Medicare Parts A and B, hospitalization, and private office visits. The Medicare Advantage plans have their own rules, and it's important that you communicate all the time because it depends on the conditions of the insured person, the age of the person insured, and how intense or strong are the conditions that they are facing. So aside from this education, I always emphasize that we have to align with the rules of your payers. However, legislations and rules are going to go and are aligned. In these updates, as I already mentioned, we eliminated 16 of the 17 codes, as we mentioned before, and the codes for telephone consultations, only audio, are not going to be valid for billing from 2025 on. We know that there's a lot of people here that are looking at, many of you are looking for accounts that can be reconciled, but you have to know that codes are not going to be paid if you use them. Medicare is not recognizing the new codes for the majority of the telemedicine new codes from COVID on. That leads us to reaching the conclusion that COVID expanded the services in the health area and the collateral effect that it caused for those services that before were not needed or we didn't pay attention to them right now can mean an expansion of services and the reach that doctors have for those patients that are in rural or remote areas. a key point here is that before billing the telemedicine information, you need to check if it's Medicaid, original Medicaid, or Medicare Advantage, and you have to know the differences in the codes. And I want to talk about the different legal issues, federal and Puerto Rico, and you have to pay attention to. The extension for the flexibility of federal services and telehealth is going to be only until December 31st, 2027. However, the extension for controlled services, and this has to do specifically in psychiatrists, is going to be December 31st, 2026. So if you are a behavioral provider services and you prescribe medication for people with mental health care issues, you're going to have until 2026, December 31st, to continue providing the services. And this means that there's more to come until they have another legislation and updating, which is always going to happen. You were fixed to provide services through prescription until December 31st, until 2026. And it's important here because not knowing does not protect you from responsibility. We know that controlled substances prescription is an area that is very important and very touchy, so you need to be aligned with the rules. The dates here are very, very important. Aside from that, Act 168, 2019 eliminated the requirement for an additional certification. This is very important for appeals in case that you are working this type of appeals for bills that were denied. You have to pay attention to this rule that you added to your appeal letter so that you can get the payment for the services. Aside from that, Act 40 of 2012 and Pierre Chairem tells us that you are providing a service through telemedicine. That doesn't mean that you're going to document it in a different way. We are going to document it in the same way. We're going to use the form. We're going to have all the demographic information of the patient. We're going to show how we provided the service, and we're going to be working aligned with the HICA law so that we can prove the medical need for the service. We cannot just think that, well, it's telemedicine, I'm going to use the modifier, and I'm not going to use anything else. We have to be aligned. We have to pay proof for that. So it's not just a modifier. We need to pay attention with the patient and work with them in the same way as if you were taking care of them in person. And this is important because when we're performing telemedicine services, the lack of documentation will have it defined as a denial in the parameters, financial parameters of an insurance plan. And what we want to do is try to have a very clean bill, because if we extend with appeals, with legal problems to be able to get a payment while you're wasting time or have the doctor focus on issues aside from patient attention, is going to be a problem. So it's very important that you keep this. This is important because it lets you know until when you can provide services in a certain mode and how to work an appeal. And now we have an idea of the legislation, expiration dates, and how we're going to be working with telemedicine. The question now is how we can provide what's legal, what's allowed, what can be done, and what not. In this area, we're talking about the HIPAA compliant platforms. We cannot use WhatsApp, FaceTime, Zoom. These are not aligned to the HIPAA compliant platforms. A key requirement here that always applies is that the platform has to have a business associate agreement, the BAA. This is a control and access control platform and deals with the privacy for patients. We received some data that in the dark web, um, health insurance is more important than any credit card. So this is why this is important. You have the name, you have the social security, you have every information that would lead to a person have their identity stolen. So this is very important. That's why CMS is so important and uh so have such strict requirements on what platform you can use. And you can go to telehealth uh, to find all this information. And one of the HIPAA compliant platforms that is always effective and recommended is Zoom for Healthcare. This is an application. You can access it through the web. You can buy the system and you are going to be aligned to the laws and you're going to be protected in case of an audit. Aside from the fact that you are keeping the information from the patients safe because a data breach is very difficult to handle. It's very costly to handle and it's better to prevent than to, try to fix it later. So this is very important information that you receive at doctor so that you can be safe and the patient data is going to be safe. Doxy.me is also a safe HIPAA compliant uh, platform. You can see here that we don't have that many HR platforms. If you want to bring it or use it aside and then bring in the information, you can use it. And then we have Teladoc and which are enterprise data, and it also works with patient information. Everything has to do with HIPAA compliance. All are safe, and it allows you to have safety with the patient information that you're handling. We know that telemedicine can be done through video or through calls, but which are the specifications that we have for the services that could have or should have video? Well, we have physical evaluations. They're going to require video because you need to see the patient. You need to evaluate the way in which maybe there's a lesion. If you're going to have another visit, there are occasions when patients feel better when the video is off, but this is only allowed when you have behavioral issues. Because if the patient feels better talking with the camera off, we're going to look for that comfort for that patient. And we're going to have that the healing process be the most comfortable for that patient. However, we have in the list dermatology. This is important because the diagnosis is going to depend on the image. We have the therapy area where the initial evaluation is going to require observing a movement. We also have mental health if the plan requires it, even though I already mentioned that there are some restrictions that can safeguard the fact that the patient, we want to have them be comfortable and we can appeal. Part of the infant exams in the pediatric area because we need to look at the behavior and a physical exam that is a visual exam. And we have the home health face-to-face, which is a federal regulation. And we don't have any safe harbor to be able to protect against in an appeal. And then we have some allowable services that are audio only, and that's going to depend on the insurance plan. So it's important, again, that you follow the rules stated by your payer. Many times, maybe we can give examples. This is just an example. I'm not saying that this happens, but it's an analogy. Maybe Triple S tells you that you don't need to see a patient using a camera, but MMM says, yes, you need that camera on. The most important thing is to offer the service, but you have to follow the rules that are set by the insurance plan, and you need to understand and be aware of the normative letters that they're constantly saying so that you are updated with them. And now we're going to go with the most important area, the money talk. We're going to talk about billing 101, how you can work and bill directly to the insurance plan with telemedicine services.
In order to bill telemedicine services, it's important to remember that simply we're going to work with the delivery method. The most important thing in these cases is to work with modifiers. And this first slide, we talk about the 93 modifier. And this modifier is always going to be together with the services that were provided only on audio, no video. And it's important from this modifier is that the place of service is going to mean a starting point for the health insurance to know how you offer the service and if you adhere to the rules. Because this is what we're saying with the place of service. When we're going to bill, we know that we always need to set the ACDCAM, the CPT, and a place of service. And in addition, the modifiers, those four things. And that's fundamental. So in telemedicine, we have two places of service, which are places of service where we're going to identify and establish the image that the medical insurance company is going to have about how you provided service. And it's important that you take a note of this because you have this on your handout. And I would like to write it down because that's how we remember. And this indicates that the service was provided to the patient, but the patient was not at home. They may have been at a clinic, uh, but it specifies that the patient was not at their home, but they did receive the service through telemedicine because the physician was not in person. An example would be a, 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 a visit after hospitalization, and this could help to close the gap because, as we mentioned before, because of the disparities that we have in terms of the physicians located in the east area versus the west area and the south and the northwest. On the other hand, we have the next place of service, which is important because it's a number 10. And here you tell the medical insurance, I provided service, telehealth medicine services to the patient while they were at home. And this activates the fee of no facility, which is higher, and it equates to a visit at the office because, as we mentioned before, we have the parity of services. So what does this mean? That we have two places of service, 02 and 10. 02 for services to the patient at the facility or at the clinic, and number 10, which is for patients who are at home. Now, in addition to explaining the place of service, we need to let the insurance company know is how we provided the service. In this case, modifier 93 is only going to be used for calls. It's a telephone call with no video. When the physician talks to the patient only on the phone, no video, they use the codes that they usually use for evaluation and management, 99202 to 99205 for new patients. Obviously, it's always going to depend on the complexity of the service, the complexity of the condition of the patient, and 99212 to 99215 for established patients. In this case, like the example we mentioned before, for a follow-up after hospital discharge over the phone with established patients. And how does this look on practice? If the physician calls the patient over the phone and there's no video, it is billed as a normal visit for evaluation and management, but uh, indicating only audio. Uh, Before, if you were billing an evaluation and management, but you are providing service over the phone, the only thing that you need to add is to the system is the modifier 93. There is no other change, no other complexity within this kind of service. If you have any questions, please, you can let us know because it's important for you to understand this information. Most of the plans instruct for the physicians uh, to describe, and here we can see the scenarios where you may find this information within your contracts. It would be in scenarios of billing for audio calls and video calls. In this case, we're going to talk about the modifier in number 95, and this modifier is used to provide or specify that the service was provided on a call with audio and video. An example of this would be a follow-up for a chronic patient or a consult after an emergency room visit. Here, the plans differentiate another scenario because they have a specification, and in this case, if it is a dermatologist, you're going to use the modifier 95, because if you use 93, you're not going to get paid because you need to see the patient. You need to see what's the physical area uh, to justify that you evaluated appropriately that patient. And the same, they're going to use the same codes of evaluation and management. And in practice, if the call complies with the criteria for telemedicine, for example, an approved platform and the appropriate documentation, you could use the modifier 95. It is important that some plans use audio calls, uh, quote unquote, to refer to telehealth without video, but under more broader uh, calls, more than a simple telephonic call. So it is important to read the small print on how it was established in terms of the contract, or if you're an administrator or a manager, it's important to validate that contract and to see if it is necessary to update it or to improve it. So it could be beneficial for the physician and to improve the financial area of the practice. And in this section, I wanted to bring you some red flags that could be seen currently in the island. First, we could use the 95 modifier when the note says phone call. This is a term that could affect all the bill. You may have all the necessary documentation, the medical necessity, but within the note, you have a video call and you write phone call, you could be denied. I am very pro working as a team, and I don't like to critique what medical insurance are doing to keep the peace. So it's better to work the system than to work against the system. So the best would be to adhere and to work directly with the rules that they are applying, because you could save a lot of time. So it's very important that within these notes, you specify if it was a video call or a phone call. If we're going to work with video call services, you should use the 95. 93, it's only going to be used for telephone calls. Another red flag within the telemedicine services, it's the lack of evidence of that interaction on video or audio. Many times you could use modifiers that are completely justifiable, and it's going to affect directly that bill. In this case, we have the modifiers that we generally use in Puerto Rico. We work mostly 95 and 93, but here we have everything that CMS applies to us, and they provide the go ahead to work with them. As we mentioned before, the documented sub-call, the modifier 95, and a mistake would be to not include the modifier. A telephonic call documented, it would be 93. A common mistake would be to use 95 incorrectly. We have the GQ modifier for dermatology to specify that we work with photos, and many times a common mistake is to bill as a visiting person. That cannot be done since it is an add-on for the list of modifiers that you may have within your billing system. Visit at a federally approved center, you could use the FQ plus 95 modifiers. A common mistake within this bill is that they omit the FQ modifier. Remember that the modifiers specify and give more detail to the medical insurance on how the service was provided, what they did, so they can understand the magnitude of the condition or the situation per se. And we have the FR modifier for remote medical supervision. A common mistake would be to use 95 without that supervision. So basically, all these modifiers in a conglomerate, they help to create that skeleton so they can indeed pay that medical bill. So in this section, I wanted to bring you what is the direct impact in Hedis and RAF, since these bills could be beneficial as well as damaging to a physician. Telemedicine impacts directly since the uh, follow-up visits and post-hospital have a rating within the citizen ref, and they help with the image of the physician with the medical insurance plan. And also these metrics, they measure the service and the quality of service of that physician with the patient. In this case, these metrics, they help to measure quality and compliance with Medicare. In this case, Advantage, as we mentioned before, they're going to have their own rules, and it depends on the patient. In addition to that, they affect the risk factor model that determines the payment and the evaluation of the plan. So it affects the star rating. And also, I always say that this is a collateral effect to provide a quality uh, service. So the stars are not a task or a punishment for any physician. From my point of view, they are just used to value you and to safeguard the effect in addition to the continuous remuneration that you receive for providing services to the patient. So you may receive bonus and you may improve your clinic's operations as well as facilities where you see your patients, etc. So this specificity in the programs that you provide to your human capital, in this case, your staff, to work in this case, uh, or billing or your front desk personnel, it's important for them to have the knowledge because they are going to have an impact in a NGO for what is your practice. Now, our recommendations for the managers within what is the administration of the office area, we know that we need to wear many hats to safeguard the practice as well so that they can learn correctly. So within what are the recommendations, we should start with verifying and validating that the physicians are using the correct modifiers. So this goes directly to keep you up to date. CMS has many educational areas where we as managers uh, could keep ourselves up to date, educated, and even though there are continuous changes and many times, let's say that they affect directly the practice because of how fast they are changing and the amount of information. Our responsibility is always to keep ourselves up to date with all information that is relieved to keep the clinic's operations. Another recommendation is to keep billing protocol. This is important because I think that the STAR SOP is going to help you to support the clinic per se and to have sustainability in the long term. And so within these manuals and billing protocols, it's important to review them every year to have sections that we know that maybe constantly changing, but they need to be updated. Another important thing is to train personnel so they can learn the difference between a telephone call and telemedicine, because when scheduling an appointment, that could really help the secretary. And many times, the secretary is also going to be on how to prepare the service, how they're going to prepare that medical record. And it's important to mention that all the documentation that you give to the patients before the appointment, they should be filled out completely, so the service could be paid. And finally, we need to monthly audit the notes for telemedicine to comply with CMS. And this is to prevent, so you may continue providing the service, and so you don't have a lot of accumulation in terms of the aging of those bills. We know that this may be counterproductive, but to keep these internal audits maybe once a month, you could analyze it. In addition to what you commonly do in a billing cycle, we know it's very extensive, but adding this could help you because the quality of these bills is going to represent an advantage for the medic physicians. I wanted to give you some practical tips. And when we are going to be working with the notes, it's important that we always keep a clear, concise, and specific vocabulary, because CMS establishes that the documentation that we're going to be working on for telemedicine is going to be the same as an in-person visit. So I have this information here that you could add it. The important thing is that it's important to keep this in the notes. This visit was performed on the name of the platform on a hyper-compliant telemedicine system. Also document the place where the patient is located at the time of the visit, because that's going to help you with the place of service that you select. Another important thing is if it is on only audio, you need to document why you didn't use video. If the patient doesn't have the technology, they may have connectivity issues. And what is the preference of the service of the patient in terms of behavioral health services? Another important thing is modifier 93, the note should say telephonic call, not a telemedicine visit. And we can see why the vocabulary is important, because this is going to improve the operational systems, including this kind of vocabulary in this billing protocol, and also in the management of the SOAP is going to increase the quality of those reimbursements. For the modifier 95, the node should confirm audio and video in real time. Again, communication. To have this kind of notes, you may have it on sticky notes. You may create templates so you can create a checklist. So when you send that bill, you already have that information in hand. Because believe me, it happens that you may have everything perfect, but if the note is not specifying that, it could be denied. And finally, what we mentioned before, to have internal monthly audits regarding the telehealth notes to verify compliance. We need to have this compliance guide. It's going to help you a lot, and it's going to improve your billing cycle within this clinic. We as patients, we have rights, and in order to receive this kind of services, and many times in Puerto Rico, it's not that the information is not available, but we don't have the necessary resources. And that's why we integrated this slide for the benefit of the people who would like to receive telemedicine services. And I think it was a great idea from the trust team, because having an educated patient is going to represent a change for the physician, because you're going to mitigate mistakes. You're going to have people that they know they are on the same page with you, and they are going to help you. So the service could be provided faster and more effectively. You, as patients in this case, you have the right to know if your provider offers telemedicine services, and you should sign an informed consent before receiving the service. If you reject it, then the service cannot be provided. That's important. And the insurance company is mandated by law uh, to reimburse telemedicine at the same fee as a in-person visit, but many people don't know that, but now we know. Your health information is protected. The provider should use a HIPAA-compliant platform, as we mentioned before. And if you cannot use video because there is no connection or disability or a personal reason, the audio only is an option for many services. It's always important to ask the provider and to learn about their policies. To prepare correctly for a telemedicine visit is important that the same way we go to an office, it's the same. You need to have your insurance card, your ID card. You need to be in a place where it's quiet, with good lighting. Test your microphone and your camera before the appointment. Learn about the platform and test it before, so that could really improve the quality of your visit. And if there are technical issues during the visit, you need to immediately call the office to reschedule or maybe change to audio only. Before we finish, I would like to show you one of the exercises that we have in the handout, if we have enough time, 5 minutes, because it's very important for me. In the handout that we share with you, we have exercise number 1, and it tells us, can you see my screen? Yes, okay, perfect. Yes, we can see it. Perfect. Dr. Garcia calls diabetic patient for a monthly follow-up. She uses telephone without video. The patient is at home. What modifier would you use, and what place of service would you use? If you want to participate, you can type it on the chat, and I am going to give you just a moment. And you can also enable your microphone so you may answer the question. The handout was shared on the chat for the benefit of everyone. And I just saw, I don't know if you are seeing the messages, but from Yvette Ortiz, she says POS 02, modifier 93. Noelia says 9310. Abigail says 93, and POS at home. Yes, I am seeing them. I wanted to answer to Francis Gonzalez, Quintana Gonzalez. Currently, the only ones used for Medicare are the ones included in the presentation. Also, I am going to show you this slide. I shared the link for the handout again for those of you who don't have it yet. Perfect. Yes, I like this. I feel fulfilled. Excellent. Place of service is going to be 10 since it was at home. The patient was at home, and the modifier is 93 since it was on audio phone call. This kind of exercise is good because you can keep this in mind when you're going to document it. If you have your biller within your clinic, or if you have an outsourced service, and you may have the opportunity of seeing and validating what way they are billing. For me, it's really important that even though you don't have the company without your clinic, so you have these one-on-one meetings and you learn what is happening with your money, why there was a denial, why you received the money correctly, so you may continue doing things correctly. So I think we're on time. If you have any questions or concerns, I am available. And if any, just let me know. Yes, thank you so much, Natashalee. Thank you for this webinar. I apologize. Don't worry. For the time being, we don't have any more questions on the chat. If there is anyone who may like to enable the microphone, you can do it now. Since we have Natashalee, you may ask her your questions. And the handout and the presentation and the videos in English and Spanish are going to be available on our digital library, so you may review them when you wish. And Jorge is going to share the link for the library on the chat, so you may visit it. And Natashalee is already uh, providing her contact information. If you would like to contact her for any questions or concerns, here you may see her contact information. If you have any questions or concerns, you can ask them right now since we have Natashalee available right now. You may type your question as well on the chat. If you would not like to enable your microphone, you can type it. Meanwhile, I am going to be sharing my screen. And here we have the survey. You can scan the QR code, or you can use the link that is available for you. It looks like you explained everything very well because we don't have any questions, Natashalee. Yes. So thank you so much. Here we have a comment from Maria. She says, excellent. You should have the survey available already. Please let me know if you can see the pop-up. If not, you may click more and click post, or you can use the link. You can click the link. Yvette, could you please refresh the page to verify if you can see it because it was uh, posted again? While you continue answering the survey, we want to talk about the next webinars that we have for this week. On June 25th and 26th, we have Ms. Gabriela Tirado. She's going to be talking to us about nutritional intervention in primary care 1 and 2. The first one would be identifying the risk and context of the patient, and the second part will be practical strategies and referral criteria. These two webinars, they do have continuous education credits, and you may register. You're welcome. Both will be at 4 o'clock on the 25th and 26th this week. We also have the ECHO series starting tomorrow. It will be running until September 30th from 3 to 4:30, and it's every 2 weeks. Also, with continuous education credits, you are welcome to participate in both, in all these activities. And very soon, we are going to be letting you know of another series that will be starting in August. So you should be receiving those emails. You are going to receive notice of that next series. We thank you. The project, thank you for engaging in this webinar. And see you next time. Thank you so much. Thank you, Natashalee, and have a good afternoon, everyone.